Good evening, everyone, and welcome onto this platform. Today, we have the fourth series, and I feel this is one of the most important series, and we are talking about communication. Communication skills perfecting the art. Why should we be perfecting the art? That is so very important to understand. While so many years we have been perfecting our surgical skills, maternity, obstetric, critical care, somewhere down the line, I've heard so many of my colleagues saying, oh, really, I don't have so much time. I have so many surgeries to perform and so many patients in the OPD. Well, we must understand that the more time we spend in our OPD rooms talking to our patients, the less is the time we are going to spend in the courtrooms. This is an undeniable fact, given the scenario that we see these days. So with that, I start my talk on communication skills. Next. First of all, we would be discussing in this today the benefits of communication, the components of communication, the general guidelines on communication skills, and I've identified 5 kinds of patients which all of you would, would understand. You would have met these kind of patients, and 4 difficult communication situations. For example, giving the bad news, the angry patient or a relative, a disagreement between patient and doctor, and disclosing medical errors and complications. Next.
I would request everyone else to kindly mute themselves so that the speaker has no inconvenience.
Thank you. What is information and what is communication? Now, these 2 words are sometimes very used interchangeably by all of us. Information is what you give out, while communication is getting through. So this is the basic fundamental difference between the kind of communication. It's a 2-way platform. Next, please. So why should we perfect the art? Well, it is very important for improving the accuracy of your diagnosis, to have a patient who's compliant with the treatment. It also affects your clinical outcomes. You get the patient's trust, you get the patient's satisfaction. Also, as a clinician, you get satisfaction. But the most fundamental important part of communication is it reduces the risk of litigation. It may not completely bring you may not completely be non-litigation proof, but it definitely reduces the risk of litigation. Now, I've had many of my friends saying, you may be able to talk to your patient well, I am not able to, express things, and, I'm such a good surgeon, I do laparoscopic hysterectomy in such a short period, 35 minutes, 40 minutes, I cannot do this. I really don't have time. So some people feel that good communication skills are something very intrinsic. It's a part of your personality. Little can be done if you're not gifted with those skills. Well, that is wrong. Good communication skills, they can be taught. They can.
Rohini, kindly unmute Dr. LEENA.
So what I said was good communication skills, they can be taught, they can be learned, they can be examined. So now coming to the components of communication. I come to a verse which is there, which, when you have seen Bharatanatyam performances, you find there is a very, there exists a very rich tradition of, these devotional pieces in the praise of the Lord. And in the praise of Lord Shiva, there are these 4 lines which are so beautiful that I really had to bring them on this platform. Angikam bhuvanam yasya, vachikam sarva vangmayan, aharyam chandra taradi, tam namaha satvikam shivam. Note the words which I have, underlined. Angikam, vachikam, aharyam, and satvikam. These are the 4 very important components of communication. Next. So what does this actually mean? This means whose bodily language, that is angikam, is the entire world. Whose speech, which is vachikam, is the language of the universe. Whose ornaments, aharyam, are the moon and the stars. Him we worship, the pure Lord Shiva, satvikam. Next. So coming to Angikam. What is Angikam? These are the gestures. This is very useful when you're short of words. Less words, more emotion. This comes in great use when you are breaking the bad news. You must not over express yourself. I mean, we don't want to be, to do some kind of a drama. But on the other hand, we must not under express. Your empathy should speak out and your words should match your gesture. So what that does mean? It also goes true for your staff. For example, if you are breaking the bad news about a missed abortion in your OPD, and you are, gently dropping the fact that, they cannot see any cardiac activity, there are no movements, and the baby is no more. At that point of time, when you are speaking in a low tone, you are expressing, thing about it, and somebody just barges in or a phone call comes in and you're saying, oh, very good, you're exclaiming and you're talking and as if nothing has happened. That sends a very wrong message. These are the important, points which have to be considered. Also, if you are in the labor room and there is a lady who's had a stillbirth, and you find that the staff is sitting around having cups of coffee, talking, laughing, discussing. So that sends a very bad message. So it's empathy which is important, and our words, what we are talking, should match a gesture. Next, please. All of us know about this movie Shakti. Films have always gone and stressed upon Angikam. So you remember that scene in the movie Shakti where you had Dilip Kumar, who played the father of Amitabh Bachchan, and they are both the father and the son. They are estranged. They haven't been on talking terms for ages, and the mother dies. Mother is played by Rakhi, and the son, that is Amitabh Bachchan, comes over, home to see the dead body of the mother, and then he realizes that his father is completely shattered. So there is this 2 minutes piece which has been put in by these, script writers, where they realize that there are no words, nothing can be said. So they just show him holding on to the hands of the father, and the father looking into the eyes of the son, and the son looking in the eyes of the father, and no words are required. Everything is conveyed in practically 1 minute. So that is Angikam for you. And that is something we all must develop and utilize in our practice. Next, please. Coming to Vachikam, a very important aspect of communication. It is the content and the tone. It is the standard of the content of your tone, of your speech, which is more important than the volume, especially in an argument. If you remember that old saying, it says that if you raise your voice and you start shouting, you've actually lost the argument. So it's very important, no matter how, how provocative it may be, not to lose your temper and not to increase the volume of your speech. Consent is a typical example of where Vachikam, the speech that you do, is going to help you in your practice. The talking part of a consent, and there is a writing part of the consent. Writing part is all the documentation. We will have talks on consent in later pathshalas, but the talking part is a vital component of our practice. So what is this? That whenever you take a consent for a particular surgery or a procedure, it's important to explain the reasonable risks and the reasonable benefits of the procedure. Give a percentage. Next. However, when you actually document, then it must be exhaustive, covering all the aspects. I give an example. You remember when we took our professional indemnity, some of us have taken it long back. When we approached these people, they said, "Oh, Dr. Saab, don't worry. You are getting a 1 CR indemnity. You can take that, and this is the yearly premium you have to pay and everything. We cover everything, anything. So we are very happy and we take it." And they explain 1 or 2 things, but nobody tells us what is AOI, what is AOY, any one incident, any 1 year. And this many times we discover when we have to actually utilize the policy. So when it is discussed, we take it and they come back to you with almost a 20-page document, which sometimes you blindly sign because you think that you have a policy which is covering all aspects. So this is exactly which is there in consent. So if there is a procedure which has a particular complication, the common complications are what you're going to discuss. 1, 2, 3, 4, 5. And Obviously, a simple example. For example, you are putting in a copper T, IUCD insertion. We all know that anything and anything can happen when you're putting a multi-load. So the common things are, bleeding, pain, expulsion, etc. So those are what you will verbally communicate. But when comes to writing, you would remember that one of the, last complications which are written is also death. But obviously, you're not going to tell death to a patient when you're communicating, because otherwise your patient is just going to run away. So when you're talking, it is important to give the reasonable risks and explain to the patient. Some very common questions which all of you have had in your practice. Doctor, please say nothing will happen to me. So how do we answer that? Well, we would say that, look, so far, in this procedure, nothing has happened to the patients that I have operated. But yes, it is written in literature, it is written in the text that there is a 0.3% or a 1% or a 5%, whatever be the percentages. And nobody can give a guarantee to anyone that nothing will happen. In that case, you could also say that I cannot also guarantee you that nothing is going to happen to me tomorrow, who is the operating surgeon. So when you say that, the patient sort of gets the message across and everyone smiles and, you manage to convey this point to the patient. The other question, doctor, please go back to the one. My friend has undergone the same operation. Now she has a problem. तो बताओ क्या करना है, मैं करूँ, नहीं करूँ, etc. I think you can just see, look, when you came to the hospital, you saw some cars, had an accident on the way. You came by car, you came by auto, you came by whatever mode of transport. And you found that, there was this accident on the road. Did that prevent you from reaching the hospital? Did you get down and decide to abort your journey? No. So the same way, this is there, that it can happen with some people, and it is not that it's going to happen to you. Will I be all right? Again, the same kind of question. Nothing will happen to me. You can also discuss it. Should I go to another doctor as he gives me 100% guarantee? Yes. Always when a patient is in two minds and wants another opinion, let them seek a second opinion. I can assure you the patient will come back, because many of my junior colleagues always tell me that no, madam, they will not come back. So we don't want to frighten them. We don't want them to, to go away from us. It's not true. When you explain things to them, they feel that you are able to understand the nitty-gritties of the surgery and what all things can happen. And it is true that once they have taken another opinion, they'll come back to you. And definitely there are no 100% guarantees. Next, please. So taking art is a consent. The procedure should seem as if it is chosen by the patient and then he feels empowered. What do we mean by that? For example, if there is a particular case and you decide in your mind that you want to do it laparoscopically, there is a column in the consent where you have got to give an alternative. So patient asks you, okay, if I am going to go for it by the abdominal route or the vaginal route, etc. And you are confident about that you want to do it laparoscopically, but it should not seem as if you have made the choice. It should seem as if the patient has made the choice. So you list out the advantages, disadvantages, and you steer the patient towards the laparoscopic surgery. So ultimately the patient would be happy, because it would seem as if he or she, she has made the choice. And most important in Vachikam is never say anything bad about your colleagues. Remember the rule of karma. What is the rule of karma? Everything good or bad that you do, eventually some way or the other comes back to you. And here I must talk about something which had happened to a colleague of mine. And that, it has happened, you have seen it, it's happened so many times in your practice also, you would have seen. The patient comes to the doctor and says that I'm 6 weeks pregnant, but doctor, how could that have happened? I underwent a tubectomy about 5 to 6 years back. So the doctor says, ठीक है, ऐसा हो सकता है. Then she starts asking probing questions कि ये कुछ गड़बड़ तो नहीं हो गई थी, कोई गलत काम तो नहीं हो गया था, ये गलत तो नहीं हो गया था ऑपरेशन. So the doctor says, no, this can happen, and starts listing out, the problems that could be, and it could happen. And then, of course, says that, oh, look, we can do a suction evacuation. You come with these tests and we will do the suction evacuation for this. So after then, by and by, the patient is convinced. Patient says, okay, I'll come tomorrow. We will do the suction evacuation. And then the doctor just in curiosity says, "Acha, by the way, कहाँ हुआ था आपका operation?" And the patient turns around and says, "Doctor साहब, आपको याद नहीं है, आप ही ने तो करा था operation." So what I'm saying is that had the doctor, bad mouth the colleague that so and so did it, when it was done, I think it was not done properly. So he or she would have landed up in deep trouble because he had himself done the surgery. So remember the rule of karma. Never say anything bad about your colleagues. I think at the end of the day, if today's talk sends this very important message, I think I would have done my job for today. So that is important in Vachikam. Next, please. Coming to Aharyam. I'm sitting at home, I've worn my lab coat. Why? Because just to stress on this point that, it's the dress that is very important. In today's very fast moving world, it is very important to dress appropriately. It is because people judge us by the dress that we wear. They judge our profession, our designation, the sincerity by your appearance. If you're well dressed, you are respected. There is an authenticity in what you're talking. It becomes easy to convince the patient, especially when you're going to take some life changing decisions. Important to wear neat and clean. It's not important that you should wear something very expensive or something very flashy, but it should be appropriate. So especially, you imagine a scenario, you're coming from some party and you have to see a patient, some fetal distress has come. So, it would be a wise thing not to appear very flashy in front of them. At the same time, you have seen many times, we have seen that, same dress. For example, when I was in the armed forces, there was a change in uniform of our nurses. And there was a time when the nurses and the lady doctors, we were wearing the same color of sari. And, the average patient doesn't look at our name tabs. So there was a difference, your sister, your doctor, there was a clash. So therefore, what I said was the dress is very important because you've seen even in the movies, the same actor is sometimes a police officer because he's wearing a police officer's dress. He's a doctor, he'll be wearing a lab coat and a stethoscope. So therefore, your dress is very important in today's fast-moving world because that's how the patients judge you. Next. And the most important of all, the most superior quality is Satvikam, that is purity. So Gandhiji, he was poor, his handwriting was poor, he didn't look so good, but he was pure. All the other things came out absolutely automatically and naturally. So when there is a connection from heart to heart, that is very important and not head to head. Put all your heart in your practice. Your emotions will connect, your speech will be perfect, there will be complete spiritual upliftment and an aura around you. And this is by and large the most important, aspect. And this is what, over the generations, doctors we have built up, because we have been kept at that level that, here is one person who has completely, pure thoughts, has a pure quality. So this is one quality which we all must excel in. Next. So what would be the general guidelines on the communication skills? So a patient comes, first of all, greet. Please call them by name. See it as an individual. Kavita, come in, please sit down. And not as a case. It's not, next please, you're the next number. It should not be like that. Discuss, call her by the name. In practically few seconds, you can define the purpose. Supposing the patient has been referred to you with, say, heavy periods. So you start the agenda by saying, okay, बहुत भारी महावारी आ रही है, तो बताओ. The whole idea will be that in a couple of seconds, you're going to say, discuss that I'm going to be discussing your symptoms, I'm going to perform an examination, arrange some appropriate tests, and discuss possible management options. This will get the patient at ease and will get the patient to discuss. Next. Let the patient talk. Tell me what is troubling you. Now, aim is to give a patient at least 90 seconds. And I read that in the NHS, they had done a study on the amount of time the doctor takes, when the patient is in the consultation room to take the history. And they've said it's an average of 23 seconds, which is really less. So your aim is to give the patient at least 90 seconds. Obviously, we cannot keep on and sitting with the patient, but, letting the patient talk. But the first 90 seconds, let the patient talk. If the patient diverts, for example, she's talking कि हाँ मुझे बहुत भारी माहवारी हो रही, then suddenly she says मेरे बाल भी गिर रहे हैं, फिर मेरे ना पीठ में दर्द हो रहा है, मेरी ना जो टांग है मेरे toes में भी दर्द हो रहा है. So she may divert. So we should tell them, okay, tell me about your periods first. You can tell me about the other problems later. But by and large, we should let the patient talk and not interrupt her. Next. Listen. It's a very tough thing to master, but the communication should be that I am there to listen to you and to help you by paying attention, by not interrupting, and by echoing. Echoing is that, for example, supposing she says, oh, I'm having such heavy periods and my back is aching, and they have seen a small ovarian cyst on the ultrasound, and my employer is so tired of me because I'm taking so many leaves. You can just say, okay, your employer is tired of you. So that sort of sets the tone that you are listening, you are understanding, and sort of the patient feels connected. Appropriate non-verbal language should also be done at the same time. So it's not that when she's talking, you pick up the phone and somebody talks to you, sister in the labor room is telling you, jaldi aa jao, the patient is fully dilated, If such a thing, obviously an emergency comes, then you will tell her that, okay, look, I will have this consultation. I'm just going to see one emergency. But it should not be that you're simultaneously talking and the patient is also talking to you. So that is very important to maintain an eye contact, and your body posture should be straight, looking at the patient and not looking elsewhere. Next. Question and discuss. Guide the patient, quiz the patient, redirect and focus. So we, how doctors, we expect a history to be like this, this railway line. But it's not like that. And how patients, they tell the history, they will not give you the LMP, then you have to go back. So once the patient is talking, you guide her back and tell her, look, I want to know first of all about your periods. You can ask her the last menstrual period. You can even quiz her how many pads are used up, per day. Are you passing any clots? And then if she starts talking about the cyst that she's also there, you may redirect her back and say, okay, we'll come to that later, but now you tell me about your period. So it's important to first focus on the primary complaint for which the patient came. After taking the history, the primary complaint, and getting all the information, then you should provide the information and share a decision making. So there is an educational sandwich called ETA. ETA is you ask the patient. For example, heavy periods are there. She's been diagnosed. She was given some medicine by a previous doctor. She also has a small cyst. She also has low back ache. You can ask the patient, okay, now you tell me, what do you think? You would be surprised. Patients have some preconceived ideas of what their disease is. It's very important because in a minute she'll say, Doctor Sahab, mujhe to lag raha hai, mujhe to cancer hai. So the patient has come out with the most important thing that is bothering her. Itna treatment kiya, tab bhi main theek nahi ho rahi hu, to mujhe to cancer hai. So then first you get from the patient what is her interpretation of her problems, and then you tell her in 90% of the cases this ovarian cyst which you are seeing is not cancer, and it is probably it's a hormonal dysfunction, and I'm going to run a few tests on you. I'm going to examine you, and we are going to come to a diagnosis. So that way you reassure the patient. After coming, telling the patient, you again ask her, because she's going to go back and tell something. So you have to make sure that the patient has understood what you have communicated in the educational sandwich. So she goes back and then she explains the same thing, maybe to her husband, maybe to her in-laws, and so they also get completely reassured on what is the information that you have provided. So remember, ATA, ATA. Next. Now I would like to identify 5 kinds of patients. You would all recognize these kind of patients in your practice. Some of the patients are balanced, they are educated and intelligent. Thankfully, a majority of patients fall in this category. They listen to what you say, you discuss with them, you give them scientific information, and they accept what you are. They ask a couple of questions which you are able to answer, so they are easy to discuss. Some patients listen only what they have in mind. They have some preconceived notions. Like, for example, I have an AUV patient, So she is afraid of cancer. You will tell her, see, I have to do a hysteroscopy. I need to take a biopsy. वो क्यों कर रहे हो, ये तो कैंसर ही निकलेगा ना. देन यू से नहीं नहीं, ज्यादातर में तो कैंसर नहीं निकलता है, ये हार्मोनल प्रॉब्लम होती है, मुझे पता तो होना चाहिए, तब मैं आपका ट्रीटमेंट डिसाइड करूँ. नहीं नहीं नहीं, तुम ना ऐसे ही निकाल दो, क्योंकि मुझे तो कैंसर का बहुत डर लगता है. तो समवेयर शी हैज गॉट दिस वर्ड कैंसर इन हर माइंड. So you have to show the opposite side to break their idea of belief. You may say, look, this so and so patients who came, they all underwent this hysteroscopy. We sent the curatings, and they were all showing non-cancer. In fact, you can say if you're in a small nursing home, etc., he says the last couple of months I have not had any cancer at all. So the patient gets a little you break that notion which is there already in their mind, because they would have these preconceived notions, and they take these and if you don't convince them, they go off from you, and they still have those notions in their mind. Next, the third kind of patient, they are very irritating. They ask the same question again and again. मैं क्या खा सकती हूँ, तो आप बोलोगे सब कुछ खा सकते हैं, कहते मैं रोटी खा सकती हूँ, मैं चावल खा सकती हूँ, मैं बैंगन खा सकती हूँ. They'll keep asking you the same thing again and again. In fact, they go out from the consultation room, and you are consulting another patient. They'll come in and say one small question again, and they'll say, such and such thing, can I eat that? So such patients you have to tackle, because you tell them, please, you write everything next consultation, and so that you don't forget what you have to say. You make them aware that that you see there is a limited time in a consultation, and you write it down so that I can address all your problems and do that. And you can also give a laughingly create tell them, say, look, your name is so and so, and you are the wife of so and so, and the wife of your husband is you. So it's all the same thing. So you can make them laugh. You can make them laugh, and same time make it very clear that that they should write down, so that everything, all the queries are answered in one go. That's very important. And there is one category of patient who have complete full trust in you. They say, Dr. Saab, aap to Bhagwan hai. I would say that, be very clear about it. Make them understand that you are not God, but you will do the best services that is possible in your with your capability, but the final result is always in God's hand. Please make them understand this, because should something go wrong, then these are the patients who very violently take an about turn, and then you are no longer God. Next, please. And the last category, which is which one should be very careful, is either those who do not understand what you are saying really, or they do not want to understand. Now, for example, there are patients who have, say, diabetes, hypertension, intrahepatic cholestasis of pregnancy, deranged Dopplers, and 29, 30 weeks. And you know that you may have to prematurely take out the baby. The mother's condition is also not good. Her diabetes is not under control. You are listing out all the risk factors to them, and you're telling them what is the plan of action and how we should be very closely monitoring their pregnancy. And then they turn around and say, Dr. Saab, और कोई रिस्क तो नहीं है, कोई रिस्क तो नहीं है, very innocently, wide-eyed, so you feel like telling them कि इसके अलावा और क्या हो सकता है? You've got everything. You have got all the medical problems. You've got all the problems with your baby, and what more? But somewhere, they fail to understand. And you tell the same thing to maybe a senior member who's come with them. They also say, Dr. Saab, कुछ भी कर लो, but हमारी बेटी ठीक होनी चाहिए, बच्चा ठीक होना चाहिए, and things like that. And even when you explain the NICU outcomes and you talk about percentages, you have your neonatal consultant talking to them, they still are not understanding. So what to do? Be very reluctant to take them. Be ready to refer them. Let them take another opinion. Do not show any enthusiasm. Don't be so ready to take, okay, I have a wonderful center, I've got tertiary, I've got NICU, I've got everything, I've got ICU, and that you can handle all the complications. If you do that and the things happen, so they would say that, look, we came to you this way and you did not say. So be very reluctant. Let me assure you, once you're reluctant, let them make the decision of choosing you as a doctor, and not that you itself told them that, this is the best center and this is the only place where we can give you the positive results. I know it is It is something, there's a very thin line in between, but that is what we all have to do, because these are the patients who would not forgive you, would bring on all kinds of problems for you should things go the wrong way.
Nishant?
Next, please. Next, please.
Nishant?
So some difficult communication situations which I think all of us have encountered in our life is breaking bad news. Now, there's so many modules and how to break the bad news. Some I can just elaborate. One is to prepare. So be ready with the questions. Take a stock of the situation, what has happened, what could be the background in it, what could be the reason. Be ready with your notes. Step 2 is give a warning note. For example, or even 2. For example, ultrasound is being done. The previous scan had shown a live intrauterine fetus, and now you find that there is the fetus is no more. So you can just say, so and so, call her by the name. He says, I am afraid कि बच्चा आपका घूम नहीं रहा है. So she says, अरे डॉक्टर साहब क्या हो गया? And the next one you say, और मुझे उसकी हार्ट बीट भी नहीं मिल रही है. So you give some time. Don't abruptly say कि ये तो बच्चा खत्म हो गया है. So give a warning note. Once you're given one note and the second note, then the third step is to play it straight. Then don't go beating around the bush. Use a non-technical language and straight very clearly कि अब बच्चा खत्म है. So that is very important. Be responsive and repeat as often as necessary, because it's like a bombshell for the patient. She suddenly goes into something like a mental paralysis. She's not able to comprehend what you're talking about. तो उसको दोबारा बोलना है और उनको समझाना है कि देखो मुझे ये दिख रहा है, ये देखो, और अब बच्चा घूम नहीं रहा है, और अब मैंने हार्ट के ऊपर डाला है और अब उसकी हार्ट बीट नहीं है. So this is very important. Wherever appropriate, give hope. Now that is mainly for some kind of bad news. A patient is, you've operated, a patient is sinking, so you can give the percentage chances of survival. So you can give that in the end if that is appropriate. Next. So the do's and don'ts of breaking bad news. The do's are, you have the facts to hand. Check if the patient wants anyone else present. It's a good idea to take the patient away and bring them in a room and explain it, maybe with another family member or someone that she wants. Clarify what the patient already knows or suspects. Most of the time when there is breaking bad news, patient already knows that something has gone wrong. Be prepared to follow the patient's agenda. Observe, acknowledge the patient's emotional reactions. That is where your Angikam really comes into play. Check the patient's understanding of what you are saying. That's very important. In between, keep asking her, समझ में आ रहा है? And if not, repeat it again. Don't give too much information at one time. Do not give any inappropriate reassurance. Once there is an IUD, there is an IUD. Please do not say, okay, let's repeat it in some center. You can go to another center. Don't give inappropriate reassurance. Answer the questions don't answer any question unless you have the facts to hand. And don't hurry the consultation. This is very important. Stop everything else that you're doing and take the consultation, leisurely. Stop emotional expressions from the patient. Yes, if she starts crying, hand her a tissue and empathize. Maybe pause for a second, but stop the emotional expressions from the patient. You also don't agree to the relatives' requests to withhold information from the patient. This is very often this happens, कि उनको मत बताना. So there is a time and a place for it. It may not be immediately, but eventually you have to inform the patient, because remember, whatever procedure you're going to do, the patient has to give consent. Next. Now come to the second difficult situation, which is the angry patient or relative. And your aim should be to resolve the conflict positively. This is only when the patient is angry, not when the patient is abusive or when there is a mob. So when the patient is angry, you listen. Get curious, not furious. Try to find out why the patient is annoyed. Is it because she didn't get an appointment? Is it because she's not happy with your treatment? Is it because she expected something and that is not happening? So try to find out from the patient. Just get curious and not furious. You empathize and deal with their emotions. Let them come out with why they are angry and take an action if it is appropriate. Now, this applies as long as the patient is angry but not abusive. With a physically abusive patient, remove yourself from the scene and call for help. Next, please. The next situation, a disagreement between the patient and the doctor. Challenge it gently but firmly. I'll give you a small example. So you had a patient and you want to, you found she has PCOD, and she wants, she's having infertility, and you decide that you want to start her on, ovulation induction. So you gently tell her that I'm going to start it this way, and the patient then takes out a magazine from her bag and says, डॉक्टर साहब वो देखो ये आया आर्टिकल कि ये होम्योपैथिक दवाई चलाई थी और उसके जुड़वा बच्चे हुए हैं, तो ये क्या है, मतलब आप दवाई में ये कर सकती हूँ. So the immediate thing is you almost feel like telling ki like this is all rubbish. Now that is the wrong approach, because she's not going to listen to you. She's going to go to that very homeopath and find out where that person is and start that kind of treatment. So you have to negotiate. Okay. Now, what is negotiation? It doesn't mean that you come down on your allopathic treatment, but you can just tell her, okay, look, now you are, having PCOD, you have been waiting for 4 years, 5 years, you're getting on in age. Look, I don't know what this kind of treatment is. I cannot comment because it's a homeopathic treatment and I'm an allopath. And I would wish to start you on this medication. You need not be worried. So we can come to a thing that, okay, you try that medication since you have already made up your mind for maybe 2 to 3 months. If it works, it's fine. If it doesn't, then you come back to me. So there is a negotiation. So avoid coercion. Avoid telling them straight away that this is not appropriate. This is one-off thing that has happened and it may be coincidental. And so therefore, you have to compromise. If appropriate, you should compromise. And very important, to consider seeking a second opinion is always good practice, so that the patient knows. Once the patient knows that you are on the right side of the treatment or in the right line, the patient is going to stay with you. Next, please. Disclosing medical errors and complications. Very important. First of all, prepare yourself. Prepare the patient. Give warning notes. After, say, a surgery that you have performed, you come out, you're telling the relatives that the bladder is, had to be repaired or there was an injury. The third step is to communicate the error. Next, apologize if that is the correct response. Now, this word apologize, while in the NHS communication thing, they have written this word apologize. We have had a series of discussions where the word sorry in Indian context is not something we should go for, because in the Indian context, sorry is like as if you have admitted that you are guilty. So you may just communicate, and only if that is the correct response, you may say, well, we are sorry that this complication happened, but it is a known, a known kind of a complication which can occur in this kind of surgery. And the fifth step, which is very important, is give the evidence that you are taking steps. ठीक है, bladder injury हो गई, अब हमने उसको अच्छी तरह से सील दिया है, हमने सो एंड सो को भी बुलाया, उनको दिखा दिया, और मुझे नहीं लगता इनको आगे वो प्रॉब्लम होगी. However, हम कैथेटर इतने दिन रखने वाले हैं. All these things should be explained. An honest approach is always the best way when such events occur. Why? Well, there have been many times, people have, say, injured the bladder, stitched it up and kept the patient on a catheter, discharged the patient on catheter and said 7 दिन के बाद आना. So there have been instances where the patient has gone home and some relatives and people have come and said, why do you having that catheter in? And they said कि वो डॉक्टर साहब ने बोला 7 दिन के बाद आना. So then they all will discuss, take him to a local doctor. The local doctor, again, as I said, karma. It is our own people who create problems for us. The local doctor would say, अरे ये पक्का bladder में injury हुई होगी, इसलिए ये catheter डाला है. Now, when the patient comes to know later, much after it, the patient is going to come back and is going to be furious, and that is when it's going to create problems for you. So, honest approach is the best way when such events occur. And very important, once the error has happened, you must give the evidence that what all steps you are taking and document all of these. So, your communication and your documentation, that will help us in these problems. Next, please. So what is the ABC of good practice? Yes, your appearance and your availability, the behavior the capability and competence. 10 years back, when I started my practice in Delhi, one of the very senior gynecologists told me this ABC. And, I kept thinking there's something to do with resuscitation. And when she told me this ABC, I realized how important it is. And we add the most important C of good practice, and that is communication. Next. And the final thing, if you can't convince anyone, well, you confuse them. And we have a lawyer in our midst, and it's actually their suggestion, some of the lawyers, they told me that, we end up, confusing them. So like you just see this, picture of Shashi Tharoor. So, if you write down, after elevating the humble Coco Nucifera to astonishing elevation, the corpulent pot-bellied bellicose leader then smashed it to smithereens over a pale white pulpit to signify dominion over ubiquitous forces. You'll be wondering what am I talking about. In short, Shashi Kapoor ne mandir mein nariyal foda. So if you can't convince them, well, let us just end up by confusing them. Of course, this is in a very extreme situation that you would be doing that. Next, please. And while a good communication is definitely very important to avoid litigation, it cannot always prevent litigation. But overall, a good communication skills is a reflection of good human nature. And that is what we should all aspire for. Next. And this is very important. Here is me with my dog. And when I say about Angikam, gestures, he is one person whom I can understand everything without talking. Each and every gesture of his tells me what he wants, whether he's, hungry, whether he's tired, whether he wants to play, whether he wants to be loved. So of all the good communication skills we should have so that we can have a good practice and we can avoid litigation. Thank you.
Thank you very much, Dr. Leena. That was very elaborate. And I think you almost touched all the aspects of communication in our day-to-day practice. We will be taking up the expert's opinion in the end. We will begin with the presentations of the right and the wrong communication. There's a small skit that we'll be presenting. Ma'am, Dr. Sonal, please take over.
Let's clap for Leena. It was an excellent presentation.
Thank you.
Thank you,
Thank
Dr.
you so
Leena.
much.
It was an excellent presentation. I think you touched on each and every point in communication. Now we move on to another session, that is what is right communication and what is wrong communication. So in the first session, we have Dr. Shakuntala and Dr. Seema with us. We shall be discussing the wrong communication first, wherein Dr. Shakuntala is a doctor and Dr. Seema is the patient. And this is a case of a primea gravida who is 6 weeks pregnant, and the ultrasound shows absence of cardiac activity. And at 8 weeks, again, the fetal heart is absent. So Dr. Seema approaches Dr. Shakuntala.
जी सीमा जी, कैसे हैं आप? क्या हुआ?
हेलो डॉक्टर।
जी
डॉक्टर, आपका बहुत नाम सुना था। मैंने पहले डॉक्टर लीना को दिखा रही थी
जी।
तो ये मेरा ना शुरू से उनको दिखा रही थी। पर
अच्छा।
ये देखो, आप मेरा रिपोर्ट देखो।
अच्छा।
मेरे को कोई दवाई भी नहीं दी और मुझे आप बता दिया कि बच्चा खराब है। मैं क्या करूं डॉक्टर? मुझे बहुत रोना आ रहा है। आप कुछ करो डॉक्टर, इसको ठीक करो बस। मुझे तो बच्चा चाहिए ही चाहिए, बस किसी भी तरह करो। क्या हो गया डॉक्टर, ये बता दो प्लीज।
अच्छा, आप रिलैक्स करो। पहले मुझे ये बताओ, आप किसको, डॉक्टर लीना को दिखा रहे थे? अच्छा। तो अच्छा, उन्होंने आपको कोई ट्रीटमेंट नहीं दिया?
ये एक पीली वाली गोली दी बस, छोटी सी खाने
इसके अलावा और कुछ नहीं दिया?
नहीं। मैं उनको कहती रही कि आप मेरे को पहली बार बताया उन्होंने कि शायद गड़बड़ है उसमें। अच्छा। मैंने बोला उनको कि दवाई दे दो कुछ और, थोड़ा ठीक हो जाएगा, बच्चे की धड़कन वड़कन आ जाए। कुछ नहीं दिया डॉक्टर उन्होंने। अच्छा। मैं बहुत दुखी हूँ। मैंने बहुत बार कंसल्ट किया उनको। प्लीज बताओ डॉक्टर।
मुझे ये बताओ कि आप का कोई अल्ट्रासाउंड भी नहीं हुआ? उन्होंने कब करा आपका अल्ट्रासाउंड?
एक अल्ट्रासाउंड किया था तब, पहले करके। जल्दी कराना डॉक्टर। इतनी जल्दी नहीं करते, मेरी मम्मी ने बोला।
नहीं नहीं, ऐसा नहीं है,
कराती।
मुझे तो लग रहा है थोड़ा देर से किया है डॉक्टर साहब ने। ऐसे तो नहीं होता है, उन्हें थोड़ा जल्दी कर लेना चाहिए था, उन्होंने तो थोड़ा देर से किया है, मुझे तो ऐसा लग रहा है। अभी वो थोड़ा जल्दी कर देते हैं, क्या पता। अब चलो कोई बात नहीं, मुझे ये बताओ कि
डॉक्टर दवाई देनी चाहिए थी ना, दवाई तो देनी चाहिए थी ना।
देखो, आपको एक पीली टैबलेट तो दी थी, पर कोई और गोली नहीं दी आपको?
नहीं नहीं, मेरी फ्रेंड ने बताया कि इंजेक्शन भी होते हैं।
अच्छा
वो बोल रही थी मेरे को तुम इंजेक्शन लगाओ।
अच्छा।
मैंने कहा नहीं, मैं
चलो,
डॉक्टर
अब
शकुंतला के
सीमा
पास ही जाऊंगी।
नहीं नहीं सीमा, अब जो भी हो गया देखिए, अब तो खैर करना ही पड़ेगा ये तो। अब आपको, क्योंकि बच्चे की धड़कन तो आ नहीं रही है, तो अब तो हमें इसको करना ही पड़ेगा। सीमा
नहीं नहीं
जी,
डॉक्टर,
करना
कोई
ही
चीज
पड़ेगा।
कर दो ना, इसको ठीक करने के लिए दे दो ना, दवाई तो दे दो कोई।
नहीं, मुझे तो लग
दवाई
रहा है
नहीं
कि
करानी मुझे।
नहीं
मैं तो
नहीं
आपके पास ठीक कराने आई हूँ डॉक्टर।
नहीं नहीं, अब तो ये
आप तो
अभी
बहुत एक्सपर्ट हो डॉक्टर, बहुत नाम सुना मैंने, इतनी दूर से आई मैं।
अब
बता, जमुना पार रहती हूँ मैं।
जी जी, अभी तो आप बहुत देर से आए हैं, अगर आप शायद पहले आते, क्या पता, मैं क्या कह
तो
सकती
मैं
हूँ।
देर हो गई मेरे को।
अब मैं क्या बताऊं, आपका अल्ट्रासाउंड भी मुझे लग रहा है लेट हुआ है।
अब क्या
आप
करूं
सिर्फ एक
डॉक्टर
ही
मैं?
टैबलेट खा रहे थे, तो अब तो कुछ नहीं हो सकता। अब तो सीधे सीधे आपका ये करना ही पड़ेगा, ये तो मुझे ठीक नहीं लग रहा है, ये तो करना ही पड़ेगा।
डॉक्टर और कुछ नहीं कर सकते?
तो आप
आगे
और
क्या होगा
क्यों
फिर?
वेट करना चाहते हो? पेट में जहर फैल जाएगा, और नहीं वेट कर सकते हैं, क्या कर
इसमें
रही हो
हुआ
आप?
क्या डॉक्टर? मेरी गलती हुई?
अब
डॉक्टर की तो हुई थोड़ी सी, मेरी क्या
हाँ,
गलती?
अब नहीं नहीं, गलती वलती तो कुछ नहीं सीमा, मैं बता सकती, बट मेरे को तो ठीक नहीं लग रहा है। बट अब वो से यही है कि करना तो पड़ेगा। और इसमें आपका जो सबसे बड़ी बात है वो ये कि ज्यादा देर वेट नहीं करो। वी हैव टू डू इट, हमें करना ही पड़ेगा।
क्या करना पड़ेगा
ठीक है,
डॉक्टर?
आप
सफाई करनी
सीधे कल आ
पड़ेगी?
जाओ। नहीं 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 नहीं, कल आप सुबह सुबह खाली पेट आ जाओ, और कल ही हम आपका कर देंगे, ठीक है? अब
नहीं
आपको
तो
बस
डॉक्टर
कल
और
आ
कुछ नहीं
जाना
कर
है।
सकते? कुछ और बता दो डॉक्टर।
नहीं नहीं बेटा, आपको कल आना पड़ेगा, खाली पेट आ जाओ, और कल ही हम
हो
इसको
क्यों
कर
गया
देंगे।
डॉक्टर? इतना तो बताओ क्यों हुआ ये?
अब देखो, इतने सारे कारण हो सकते हैं, क्या बोल सकते हैं, पता नहीं आपको। टैबलेट्स का, अल्ट्रासाउंड का मैं क्या कह सकती हूँ। ये तो
बहुत गलत हो गया।
बस अब
मेरे
आपको
को
कल
आगे क्या होगा? मेरा आगे ठीक हो जाएगा? आगे
देखो,
कैसे करूंगी
आगे
मैं?
के बारे में क्या कहेंगे, पहले तो आप कल खाली पेट आओ, कल हम आपका करेंगे, ठीक है? पहले कभी कुछ हुआ है ऐसा आपके
नहीं
साथ?
डॉक्टर, पहली बार मेरे को प्रेगनेंसी पहली बार हुई है।
अच्छा अच्छा,
शादी को ही अभी 8 महीने हुए हैं।
अच्छा अच्छा, चलो आप कल खाली पेट आओ, हम आपका ये करते हैं, ठीक है? फिर उसके
Thank you,
बाद
Dr.
हम आगे
Shkuntala.
बढ़ेंगे।
Thank you, Dr. Seema. I think this was a very good example of wrong communication. And now we move on to good communication. So, Dr. Shakuntala will be the patient, and Dr. Seema is going to be the doctor.
डॉक्टर साहब,
हेलो
मेरे साथ बहुत
शकुंतला।
खराब हो गया है, मैं क्या बताऊं आपको, मेरा तो
बैठो
बहुत।
बेटा, बैठो, पहले बैठो। क्या हुआ
अरे
बच्चे?
मैं डॉक्टर साहब बहुत नाम सुन के आई हूँ आपको, मैं तो बड़ा, मेरे साथ नुकसान हो
नाम?
गया है। मैं डॉक्टर लीना के पास जाती थी, पता है आपको? मैं
अच्छा
डॉक्टर लीना के पास गई पहली बार, बड़ा नाम सुना था उनका,
अच्छा अच्छा।
और उन्होंने मेरा अल्ट्रासाउंड बड़ा लेट कर दिया। उन्होंने मुझे सिर्फ एक पीली गोली खिलाई, और कुछ किया ही नहीं उन्होंने मेरे साथ।
पर बेटे, आपने अभी शादी, आप बता रहे 8 ही महीने हुए आपकी शादी को,
हाँ जी,
पहला
हाँ
बच्चा है,
जी, हाँ
तो
जी।
बेटा पहले बच्चे में इतनी दवाई देते हैं? किसने बोला आपको कि और दवाई देनी होती है?
पता नहीं, मेरे को तो सारे, मेरी मेरी सासू माँ भी यही बोल रही थी,
नहीं
और मेरी तो नंद ने भी यही बोला कि
देखो,
डॉक्टर लीना
गलत
ने आपको
बोलते, वो
सिर्फ एक
डॉक्टर
टैबलेट
नहीं है
क्यों
ना।
दिया?
नहीं नहीं, डॉक्टर नहीं है ना। 3 महीने ना, पहले 3 महीने कोई दवाई नहीं देती, क्योंकि किसी भी दवाई का वो गलत असर पड़ता है।
नहीं नहीं, तो डॉक्टर
देनी
साहब
नहीं
ने,
होती।
डॉक्टर लीना ने मेरे को सिर्फ एक दवाई दी, वो ठीक किया।
बिल्कुल ठीक किया बेटे। क्यों? क्योंकि अगर बच्चा जब ठीक होता है ना, मान लो अगर अपना बीज सही लगा, तो पेड़ सही अपने आप बनता है, उसको कोई और नहीं देना होता।
अच्छा
सबसे पहले 3 महीने में हमें खाली छोटी गोली खानी होती है। आप खा रहे थे बेटे,
अच्छा।
ये तो
और
ऐसा हो जाता है।
उन्होंने मेरे अल्ट्रासाउंड पे अल्ट्रासाउंड करती गई, अल्ट्रासाउंड किया, फिर दूसरा अल्ट्रासाउंड कर दिया। ये क्या होता है, मेरा अल्ट्रासाउंड से खराब नहीं हो गया बच्चा?
नहीं नहीं, पहला अल्ट्रासाउंड करना इसलिए जरूरी होता है कि देखना होता है कि बच्चे की धड़कन कैसी है, क्योंकि हम किसी और तरह से देख ही नहीं सकते ना।
अच्छा
हमें खाली अल्ट्रासाउंड से ही पता लगता है कि बच्चा कहाँ है, कैसा है, कितने टाइम का है, धड़कन आई कि नहीं आई, ये सब हमें अल्ट्रासाउंड से ही देखना पड़ता है बेटे। तो पहला अल्ट्रासाउंड बिल्कुल ठीक टाइम। और देखो, उन्होंने 15 दिन गैप भी डाला, आपको बताया था ना उन्होंने कि अभी
हाँ,
ठीक
बताया
नहीं है,
तो था,
धड़कन नहीं थी।
डॉक्टर साहब ने बताया था,
बिल्कुल ऐसे
लेकिन
ही
मेरी
होता है।
सास तो कह रही थी कि इतने अल्ट्रासाउंड नहीं कराते।
नहीं बेटे, अब अपने जमाना बदल गया, अब अपने पास फैसिलिटी है ना, पहले जमाने में होता ही नहीं था। तो कुछ होता ही नहीं था, इसलिए 3 महीने घर पे बैठो। तो ऐसा होता है, बिल्कुल ठीक किया डॉक्टर लीना ने।
डॉक्टर साहब
और देखो इसका मैं तुम्हें कारण समझाती हूँ, तुम ध्यान से सुनो इस बात को। देखो ऐसा ना, ये कई बार क्या होता है कि जैसे अपन कोई घड़ा बना रहे हैं, कुछ भी बना रहे हैं, और कभी भी पानी मिट्टी कुछ भी ज्यादा हो गया, कम हो गया, तो उसकी शक्ल बदल जाती है। ऐसे ही बच्चा होता है ना, उसमें क्रोमोसोम्स की प्रॉब्लम हो जाती है, जेनेटिक प्रॉब्लम होती है। तो 90% ना पहले 3 महीने में जो अबॉर्शन होता है वो उसके करके होता है। अपन देखेंगे, इसको पता करेंगे, आप चिंता नहीं करो।
अच्छा, तो ये जो सब लोग बोल रहे हैं कि डॉक्टर की गलती से हो गया, डॉक्टर की गलती से हो गया,
ऐसे नहीं बनाती बेटे शकुंतला, आप तो समझदार बच्चे हो, पढ़े लिखे बच्चे हो, आप ऐसी बातें बिल्कुल नहीं करोगे। आज के जमाने में बिल्कुल ठीक ट्रीटमेंट हुआ, और ऐसा ही करना होता है।
अब मुझे क्या करना होगा डॉक्टर साहब, अब मैं क्या करूं?
देखो अपने पास 2 मेथड है भी, हम आपको दवा भी दे सकते हैं। हमें अब तो ये जो प्रेगनेंसी है इसको अबॉर्ट करना होगा, तो या तो हमें दवा देनी है, या फिर हमें इसको सर्जिकली अबॉर्शन करना।
मैंने तो सुना था कि सर्जिकली करना पड़ता है, मतलब कि आप मेरा उसको निकाल के साफ कर देंगे और सफाई हो जाएगी। दवाई भी होती है?
देखो दवाई भी होती है, 95% अपना उससे हो जाता है, 5% कई बार नहीं होता, तो हमें सफाई करनी पड़ती है।
अच्छा, तो
आप दवाई डेफिनेटली ट्राई कर सकते हो, पर आपको थोड़ा सा समझना पड़ेगा कि ब्लीडिंग भी होगी और पेन भी होगा, इन दोनों को बर्दाश्त करना पड़ेगा। आप परेशान नहीं होगे, आपको 10 दिन वेट करना पड़ेगा। और बीच में कुछ भी प्रॉब्लम थी, आप मेरे पास आ सकते हो।
अच्छा,
दूसरा ट्रीटमेंट भी कर सकते हैं, पर आपको ये सोचना पड़ेगा कि क्यों हॉस्पिटल एडमिट हूँ, क्यों सफाई कराऊं। पहला बच्चा है, आप दवा से ट्राई कर सकते हो, पर आपको इसको समझ के घर में बात करके मम्मी पापा से फिर करना है। बट सबसे पहले आपको टेस्ट कराने बेटे। आपके कुछ टेस्ट हैं जो बेहोशी के लिए और अपनी दवाई लेने से पहले करने होते हैं। खून चेक करना पड़ता है, ब्लड ग्रुप देखना पड़ता है ना। वो सब तैयारी कर ले लो, आराम से आ जा, कुछ ऐसी चिंता नहीं है। कोई ब्लीडिंग तो हो ही नहीं रही तुम्हें।
हाँ, ये तो है, ब्लीडिंग नहीं हो रही है। हाँ जी, ब्लीडिंग तो नहीं हो रही है। अच्छा डॉक्टर साहब, इसके बाद मेरा जो फ्यूचर में दोबारा से कोई चांस तो नहीं है कि मेरा फिर से बच्चा खराब हो जाएगा? मैं क्या करूं अब, आगे के लिए मुझे क्या करना होगा? मुझे मैं एक और डॉक्टर के पास गई थी, उन्होंने तो कहा था कि सुबह खाली पेट आ जाओ, और आगे के लिए तो फिर उन्होंने मुझे कुछ बोला ही नहीं।
आगे के लिए भी अपन ट्रीटमेंट करेंगे। पहले अपन 1 महीने का गैप डालेंगे, उसमें थोड़े टेस्ट भी कराएंगे। तुम बहुत ही ज्यादा चिंता कर रही हो, तो हम ये भी देख सकते हैं कि इसमें क्या प्रॉब्लम है, पर उसका कोई फायदा नहीं होता। पर मैं तुम्हें खाली बताने के लिए बता रही हूँ कि कई बार जेनेटिक जो प्रॉब्लम है वो टेस्ट में आ जाती है। उसकी जरूरत नहीं है, पर जब आप सोच रहे हो कि मुझे बताया नहीं, तो मैं इसलिए पहले बता रही हूँ। आप चाहो तो वो टेस्ट करा सकते हो, और बेहोशी में कल हम कर भी सकते हैं, पर मुझे लगता है तुम्हें वेट करना चाहिए।
ठीक है
तुम्हें जो चाहिए घर में बात करो, टेस्ट कराओ, फिर मेरे पास।
ठीक है मैम, thank you doctor sir.
Take care.
Thank you, Dr. Seema. Thank you, Dr. Shakuntala. It was an excellent example of good and bad communication. I think in a situation where patient is in trouble, first we have to be very compassionate towards the patient, and secondly, we don't have to speak ill about the previous doctor who has been managing her. And the third thing is that you have to manage her as per the medical guidelines. Any other comment from the experts?
So we'll take the comments in the end. There is one more case presentation that will be done by Dr. Suman Bishnoi and Dr. Seema.
Dr. Sonal.
Dr. Sonal. Yes, ma'am. Dr. Sonal. Dr. Suman and Dr. Sonal, please go ahead.
नमस्कार डॉक्टर साहब।
नमस्ते सुमन, कैसे हो?
हाँ, मैं बिल्कुल ठीक हूँ, आप कैसी हैं?
मैं भी बहुत अच्छी हूँ। बताओ बेटी,
आज मेरे को आपने बुलाया था डिस्कस करने के लिए कि मेरी जो प्रॉब्लम है उसका आगे क्या सोल्यूशन है। आपको मेरा केस तो पता ही होगा।
हाँ सुमन, मुझे मालूम।
आपने मुझे ये बताया था कि आपको एंडोमेट्रियोसिस नामक बीमारी है। पहले तो मुझे डिटेल में थोड़ा सा ये बता दो कि होती क्या है। और मेरे 2 बच्चे भी, मैं तो शुरू से ही, मैं सिर्फ आपको ही जानती हूँ, मेरे सिजेरियंस भी दोनों आपके पास हुए। उसके बाद मेरे सिस्ट विस्ट आपने बताई थी, वो भी आपने करा, और अब आप फिर कह रहे हो कि आपको बहुत सारी प्रॉब्लम्स है। तो प्लीज मुझे थोड़ा सा बता दो।
देखो, तुम्हारी उम्र जो है ना 39 ईयर्स
39 है। हाँ जी।
और तुम जानती हो कि तुम्हें एंडोमेट्रियोसिस है। सबसे पहले तुम मेरे पास इनफर्टिलिटी के लिए आई थी, 8 साल हो गए थे तुम्हारे।
For that I am very thankful to you. You have given me 2 beautiful children.
हाँ, उसके बाद तुम्हारे बच्चे दोनों हो गए। पर तुम्हें एक चीज मैं बताना चाहती हूँ कि जो ये एंडोमेट्रियोसिस नाम की तकलीफ है ना बेटा, ये बार बार वापिस आती है। ये पूरी जिंदगी तुम्हारे साथ चलती है, तुम्हारा पीछा नहीं छोड़ती है। ठीक है ना? तो तुम्हें इस चीज के लिए प्रिपेयर्ड रहना पड़ेगा। जो अंदर तुम्हारी बच्चेदानी के अंदर की लाइनिंग है, वो कुछ सेल्स बाहर पड़े होते हैं और वो हमेशा रहते हैं, उनको हम हटा नहीं सकते। सो तुम इस समय परेशान हो कि तुम्हारे
मैं
को
बहुत
sexual
बहुत
function
ज्यादा
में भी
परेशान हूँ, मेरी
परेशानी
तो
है।
जिंदगी खराब हो गई है। मैं क्या करूँ, मेरा हस्बैंड भी इतना दुखी है मुझसे, मैं कोई सेक्सुअल लाइफ नहीं मेरी, मेरे सारा दिन दर्द होता रहता है। डॉक्टर साहब मुझे बचा लो प्लीज।
बेटा देख, इसमें ना तुम्हारे पास चॉइस है कि पहले तो तुम, इम्पोर्टेंट चीज है कि पहले तो तुम्हें पेन किलर रेगुलरली खा लेना है अपने पीरियड्स के टाइम पे,
अच्छा,
ना? और उसके बाद तुम डेफिनेटिव क्या तुमने ट्रीटमेंट लेना है उसके बारे में सोचना है। देखो
वही
दो
वही
हमारे
वही
पास
जानने के लिए मैं आज आपके पास आई हूँ। आप मुझे बता दो, दवाइयों से ठीक कर दो प्लीज मुझे। मेरे को ऑपरेशन से बहुत डर लगता है।
देखो इसमें दो इम्पोर्टेंट एस्पेक्ट्स हैं, या तो हम मेडिकल मैनेजमेंट दे तुम्हें या तुम्हें सर्जिकल मैनेजमेंट दें, है ना? अगर मैं तुम्हें मेडिकल मैनेजमेंट देती हूँ तो तुम्हें जो गोली में तुम्हें 2 महीने से शुरू करी हुई है एंडोरेग नाम की, जो
हाँ, उससे मेरे को तो काफी काफी फर्क है, काफी
उससे
फर्क।
फर्क है, तो या तो उसी को कंटिन्यू कर लेते हैं जो कि हम 65 मंथ्स तक ले सकते हैं, उसमें कोई परेशानी नहीं रहेगी, है ना? और अगर फिर भी तुम्हें तकलीफ दे रही है तो हम लोग एक मेरीना नाम का डिवाइस होता है जो कि प्रोजेस्टेरॉन से लोडेड एक डिवाइस होता है, वो हम तुम्हारी बच्चेदानी के अंदर रख देते हैं क्योंकि तुम्हें और बच्चे तो अभी
अच्छा,
चाहिए नहीं
उसके
है।
मैंने तो सुना था वो कॉपर्टी जैसी कोई चीज होती है क्या?
हाँ, तो
सुना
तुम
था
क्या
वो
है
ऊपर चढ़ जाती है अंदर।
बहुत रेयर चांस होता है कि वो ऊपर चढ़ती है, मैं ये नहीं कह सकती कि वो ऊपर नहीं जाएगी, बट रेयर, बहुत ही रेयर चीज होती है कि वो ऊपर जाएगी। 0.1% रिस्क होता है उसमें बच्चेदानी के ऊपर।
और मैंने ये सुना था वो बहुत महंगी होती है।
नहीं नहीं, आजकल वो महंगी नहीं है, वो 2,500-3,000 रुपए की आती है। और हम तुम्हारे को, पर उसके लिए तुम्हें दाखिल करके मेरे को अंदर से एक बायोप्सी लेके, और अगर बहुत बड़ी तुम्हारी गांठ है उसको क्लियर भी करने की अगर तुम्हें जरूरत है तो वो भी कर सकते हैं, और साथ में मेरीना डिवाइस डाल के 5 साल के लिए तुम्हारे अंदर छोड़ देंगे, फिर अगले 5 साल तुम उसको रिपीट भी कर सकती हो।
अच्छा, वो तो बहुत अच्छा होगा
क्या
फिर
है
तो।
कि तब तक तुम्हारा मेनोपॉज आ जाएगा, है ना? कुछ इंजेक्शंस भी अवेलेबल हैं, पर वो इंजेक्शंस मैं तुम्हें नहीं सजेस्ट करूंगी क्योंकि उससे तुम्हारी हड्डी कमजोर पड़ जाएगी,
ओ,
है ना? तो और दूसरी ऑप्शन तुम्हारे पास है कि क्योंकि 2 सर्जरीज तुम्हारी पहले हो चुकी है एंडोमेट्रियोसिस के लिए, अगर तुम चाहती हो कि डॉक्टर साहब अब इसको सब कुछ को निकाल ही दो, बच्चेदानी भी निकाल दो,
हाँ डॉक्टर साहब, मैं भी यही सोच रही हूँ कि 40 साल की तो मैं होने वाली हूँ,
वो ऑप्शन अगर है
बच्चे भी मेरे बड़े बड़े हो गए हैं, अब तो निकाल ही दो आप इसको।
वो भी
मेरे
कर
को ये
सकते
बता
हैं
दो।
कि हम सब कुछ निकाल दें, पर उसके बाद तुम्हें एक हार्मोन की दवाई खानी पड़ेगी जो तुम्हें तकरीबन 7-8 साल और खानी पड़ेगी ताकि तुम्हारी हड्डी ना कमजोर पड़ जाए। देख बेटा, अगर हम बच्चेदानी के साथ अंडेदानी भी निकाल देते हैं तो हड्डी कमजोर पड़
नहीं, आप मेरी सिर्फ बच्चेदानी निकाल दो क्योंकि मुझे उसकी जरूरत नहीं है। अंडेदानी तो छोड़ ही दो आप अंदर।
अंडेदानी छोड़ेंगे तो फिर ये बीमारी ठीक नहीं होएगी ना।
फिर मैं हार्मोन्स तो नहीं
हो
खाना
जाएगी।
चाहती। मैं तो हार्मोन्स, मैंने सुना है बहुत नुकसान करते हैं, हार्ट अटैक हो जाता है।
हाँ, तो तुम हार्मोन अगर नहीं खाना चाह रही हो तो तुम्हारे पास ऑप्शन है कि हम इसको क्लियर कर दें और सफाई करके दूरबीन से देख के अंदर एक मेरीना नाम का डिवाइस डाल दें। आई थिंक वो तुम्हारे लिए बहुत अच्छा
क्या
रहेगा।
करूं? ठीक है डॉक्टर साहब, मैं अपने घर में डिस्कस करके अपने हस्बैंड से फिर आपके पास आती हूँ दोबारा।
हाँ, आप डिस्कस करो, मैं आपको ये प्री ऑप इन्वेस्टिगेशंस लिख करके दे रही हूँ,
थैंक
ये
यू
सब
सो
करवा
मच, थैंक यू
Thank
सो मच।
Thank you very much, ma'am. Very nicely played the rules. And Dr. Sonal is now rightly communicating, guiding the patient, informing the patient, and educating also. And at the same time, giving her the options properly and giving her time to decide and take her own time to proceed further for the treatment. I think this is the right communication, and I think we have learned a lot from Dr. Leena's talk. Thank you very much.
I would request Dr. Shardajan ma'am to open the comments on her expert comments on the communication skills and the whole session. Ma'am. Ma'am, you are muted.
Basu being the guest of honor today, I think let her speak and then I will follow. Dr. Basu? Now what I can see that, Dr. Basu, are you there?
Yes, I'm there. I'm very much there. No, but I think please you do the honors first. You are muted हैं आप.
Ma'am.
Hello.
It was an awesome presentation by Dr. Leena. She covered each and every aspect. And we all know that the 3 pillars are there to avoid medico-legal issues with ourselves, and that is communication, documentation, and consents. So I think, if the communication part is good, then I think, 80% litigations can be avoided. We all know everybody talks these days of a good PR thing. And this PR is nothing but the patient communication. I think that particular part has to be really good. Till we were there in medical colleges, this is not taught in the four walls of the medical college, but now there is the importance has been appreciated. And now undergraduate course, there is this soft skills are being taught, because we definitely want every medical student should learn these techniques. Question is often asked कि भाई जो अच्छा communicator है वो तो अच्छा है, इसको learn नहीं किया जा सकता. But I think that's wrong. We can definitely learn the right communication skills, and we need to know the language properly. And I think in these two things, the two tools which are there with us are listening and empathy. These things must be conveyed to our patients time and again. You saw in the three presentations which had been there, that the people who are, the doctors who are empathetic and who are trying to listen to them, sort out their problems are one by one. I think these things are very important. And I again will say, if you do a wrong communication and if you do not communicate well, the litigations are going to be plus, plus, plus. And I think that particular part can be avoided to a large extent. So with these remarks, I will say that, we got to learn a good communication skills. And that's what I would like to say at this particular time. We'll take it up later. Dr. Basu.
Thank you
Madam
very
Dr.
much.
Basu.
Thank you very much indeed, Dr. Jain, for having given me the opportunity at this last moment, because, I wasn't aware that this was going on for, again, a communication gap. However, I think Dr. LEENA did a very great job in, covering all the aspects. We can go on and on about communication and the various aspects of it. She has covered everything. Obviously, communication requires a lot of time to learn. You see, a lot of what we are talking about communication is nothing but courtesy. Previously, we learned it as role models from our teachers, but there were joint families where people learned empathy by watching others. But now with nuclear families and the children moving out into hostels, and all their learning is done, at a very impersonal level. The online teaching is also not helping with empathy and all those things. So whenever we get it, that is why it has to be now introduced as a curriculum. Previously in India, it wasn't that bad. It was the empathy was there, the communication was there, the courtesy and respect was there. Obviously, when people got annoyed, we had to tell them to, control your temper. There's one thing which I always feel, having watched, our doctors when they communicate, is everybody seems to be in a rush to get to a decision. And that is somewhere where we should put a hold. Let the patient mull over it. Whatever advice we give them, we should give it in pieces. As Dr. LEENA had brought this out, that if we give all the information in one go, then obviously they are not able to, even if we put ourselves in their place. And I'm a gynecologist. And if a cardiologist begins to explain to me everything, in their technical knowledge, I would also be at a little loss as to how, how to comprehend it. So coming down to the level of the individual that we are speaking to, for example, in the second skit, the patient was a very, evolved and very considerate and a good patient, what we call, and easy to communicate with. First patient was trying to pinpoint कि किसी पर fault ही निकाले. So, you have to alter your ways of communication depending upon the person you are dealing with. And so one thing is basic courtesy. The other thing is getting them in pieces, the information to be rolled out. So you give it in little chunks and then check. Little chunks and then check whether they've got that part correct or not. Another important thing I feel, which all of you do it, I find all of you are excellent communicators, that is why you have reached where you all have, is that why did the patient choose to come on that particular day to you? The day we can address that point, she may be having menorrhagia for 6 months. She may be having any other problem for a long time, or even fever or pain abdomen, but she chooses to come to you on that particular day. when we can find out why they came on that particular day, half the battle would be won, because that is the concern. Otherwise, quite often we take a very good medical history, everything is there, but that concern has not been addressed. So quite often they will go back and think, "यो, मेरी बात नहीं समझे, बात इसलिए नहीं समझे कि हमको पता ही नहीं है कि आपने बताया ही नहीं." But then it is an art that we have to develop as to how to get to that bottom, what is bothering them. And that would be an important part of that communication. कि दुखी क्यों हो रहे हैं उस दिन? हो सकता है somebody comes with you in fever, कहा तो इतने दिन से 2 दिन से fever था, उसके पहले नहीं उसके बाद घर वालों ने ऐसा बोल दिया, फिर ऐसा बोल दिया, bleeding मेरे को हो रही थी, बोली थी मेनोपॉज में होता ही रहता है, फिर मैंने ये दवाई खाई, वो दवाई खाई, और लेकिन अब आई हूँ आज क्योंकि उसको किसी के बगल में पता चला कैंसर हो गया. So now she runs to the doctor. So but the moment you know कि this is what she brings on the table, then I think half the battle is won, and we can take a history subsequently accordingly. And many a time when we take the history, many of them ramble on, which Dr. Leena had also pointed out. Rambling on, then we have to bring it to closed questions. She did give an example that, okay, you say, कि, first let's talk about this and then we'll talk about this. That is, asking closed questions so that you bring them onto the line. But still many will say, कि नहीं आप मेरी बात तो सुनिए, So sometimes you have to just keep quiet and listen. What else can you do? So the moment they feel कि, okay, you're willing to listen, probably things will be easier. There's no perfect way of doing things. It is something that you get some basics and improvise on the situation. And another thing is that quite a lot of the time, I have seen many doctors who are on appears to be that they are on an ego trip. कि मैं ये कर लेते हैं, हम ये कर लेते हैं. Don't ever try to be playing God, which also has been highlighted, and say कि नहीं हम ये कर लेंगे, वो कर लेंगे, बहुत अच्छा उनको नहीं आता करने के लिए. जो skit था उसमें भी ये चीजें आई थी in some little measures. I think one should not be an ego trip. भैया हम human हैं, I do it to the best of my ability. And never be scared कि patient भाग जाए, पता नहीं किस्मत हमको किस चीज से बचा रही है, अगर भाग ही जाता है. So I think we should stay with that. जो है उतने में हम ठीक हैं. I think, but otherwise, this was an excellent session, and I must congratulate Dr. Sharda Jain and all her team and all the members for having, had this wonderful session. Congratulations to all.
Thank you, ma'am. Ma'am, in the skits that we presented, in the first skit of the wrong communication, basically the doctor was trying to put the blame on the other doctor. In the second session, the patient was very restless. She was not letting in the right communication. The patient was so restless that she was not allowing the doctor to speak, but the doctor made the patient comfortable. In the third skit, the doctor and the patient both were extremely sophisticated. So that the purpose was basically to highlight the various scenarios. Thank you very much, ma'am.
Yeah, that is what I'm saying, that you have to, adapt yourself according to a particular. There can be no hard and fast rule. There are only basic principles, and you improvise as you go along.
Thank you very much, ma'am. Thank you. I invite Dr. Ragini Agarwal to give her expert comments, please.
Very good evening to all of you. First, I can say that Dr. Leena has spoken so well and covered everything, and the skits are really very, very wonderful. But my take on all communication is little different from all of you. Because today, whatever your communication tools Dr. Leena has said, they are very, very right. We should have those tools in our hand. First, because every single patient is medico-legal, can do a medico-legal. So never thought that his patient is very sweet, very nice, or my old patient. The moment anything happen, she can convert to a litigant. So the question is that till how much time we will be always learning, and doing all the communication from our side. When we will start really teaching to others how to communicate us? That is also a question, and we should have a discussion on this also, because every blame finally comes on the doctor's head. So this type of communication is also a part of our learning, number one. Number two, which is more important, is when a patient comes to us in our busy OPD. At that time, it is not possible that you are go on discussing and everything. So we should also learn where to stop, where to say no, that now the time is enough for the discussion and you have come for another time. As Dr. Leena has said, she came for this bleeding PV and then start talking about all the symptoms. And the long back, they start talking about the symptom of the husband and SARS and everyone. And there was very special thing, hamara bhi blood pressure le lo, those kind of thing. So we should learn that how to stop the communication in the time so other patient who is sitting is not getting irritated. And when you try to rush, that goes against you. So you have to learn this thing that when you patient call again, and specifically a condition like PCOD and all, we should all have a something like counseling. They cannot be covered in the consultation. So my only thing is that we should think about the communication on the other side also.
Thank you very much, ma'am. Actually, when we are asking for your expert opinions, we are really wanting to have your experiences and valuable inputs in which we can gather more knowledge on communication skills. I would invite Dr. Sanjeevani ma'am to now deliberate, please, ma'am.
A lot has been said after the brilliant talk and the the scenario presentations. A lot has been mentioned by the experts, and everyone. Yes, like Dr. Ragini said, she has a different take on it. I agree fully with that, and I think Dr. Leena has stimulated. That our epics like the Ramayana and our Vedas, which are the oldest scriptures, if we have some knowledge of those, they help us in shaping ourselves to communicate better. So it is very interesting to note. We may speak. Ragini said we should have communication from the other person also. It should be little interactive after we have provided information. Now, if you see the Rig Veda will teach you politeness and humility. So you have to maintain that as a part of your personality. Yajurved will give you the power of remembering. So you remember a previous episode of a similar type. And Samved gives you some shrewdness and some depth of understanding. All these will also help in communication and in understanding what's going on in the interaction between you and the patient. If we read our Vedas, we are going to be very good. Now, all present here, all who have presented, every member of this team, they are all like Ram was called Vakmi Shriman. Vakmi Shriman means expert in talking. So we can learn how to become experts in talking, experts in communicating, but we cannot always expect the same from the other person. So how do we communicate if we are talking to a person who is non-communicative? How do we train a postgraduate who does not speak out? So we'll have to teach her to communicate so that she is able to communicate with the patient. So these some skills can be acquired if we read our epics and we read our Vedas and we learn that a previous interaction, a previous communication of a similar nature should have some impact on our memory. So I would suggest please read in brief the Vedas. And Ram was Vakmi Shriman, but when Hanuman spoke to Lakshman and Ram the first time, Ram told Lakshman to reply. But when Lakshman started replying, then Ram stopped him. So Lakshman said, "Why are you stopping me? You told me to reply to Hanumanji." So he said, he has spoken so well that think and reply. So when we are communicating, we should constantly judge the other person, be shrewd in that, learn that from Samved, learn what happened in a previous episode from Yajurved, and learn from Rigved that despite everything and anything, we have to be polite and humble. So these are just some random thoughts I wanted to put across uh, to form a basis for our communication skills, and try and gather more from a little bit. Like sometimes you have to extract the juice from a few words, a few sentences a patient speaks. Try to gather its nectar. She may not speak as much as you. If you ask me, Shakuntala, you ask me to speak on something, I'll go on speaking extempore. But you can't expect it from everybody. So try and understand her. You cannot teach a patient that you should communicate better. What is this? You are not even telling. Patient situation is different. But if you are communicating with a colleague who may have to communicate with the patient, then you must make her learn to communicate. So that is what Dr. Ragini said about, teaching others also how to communicate when we have the chance. Thank you.
That was very thought-provoking, ma'am. Very much connected to our ancient rich history. Thank you so much. I invite Dr. Sadhana Gupta to give her valuable opinion. Thank you very much.
Thank you. I think this evening was a very wonderful evening because we really went beyond typical medicine, and Dr. Sanjeevani and Dr. Leena rightly says that actually without purity and some spirituality, the medicine is all about human body and it is safe. मैं दो तीन चीजों को कहना चाहूंगी जो मैं लाइक लास्ट 10 years में लोगों को बदलते हुए देख रही हूँ. फर्स्ट थिंग दैट इन एनी कम्युनिकेशन a doctor should not give direct or indirect sense of two things. One is fear and one is challenge. How could you challenge my capabilities? And secondly, fear, this person can have potentially damage us. Because like I read in any thing, when there is a fear, when there is a doubt, and when there is a ego, then the already whatever right words you speak, you are not going to really break the barrier. So it is not only in the bad situation, it is throughout our medical career, and we can say throughout our life, even when we are traveling or something, that the ego and fear should not be there.
Exactly.
We are professionals. Secondly, what we say that professional and a very very इमोशनल आउटबर्स्ट. क्योंकि मेरा मानना ये कि जिसको हम आजकल लोग एक मिस अबॉर्शन पे इतना रोना पीटना मचाते हैं, लाइक ना लाइफ इज मच परफेक्टेड, लाइफ इज गोइंग टू हैव मोर challenges for everything. So this is very important that professional is counseling is not a pampering. You have to be very very clear about it. Yes, this is this thing, we can do this thing, and the thing finishes what Ragini says about time. It does not take, professional counseling does not take time. कई बार पेशेंट आते हैं, बोलते हैं, बार बार बोलते हैं ये चीज, फिर अब अभी ये बच्चा नहीं है, फिर 3 साल बाद क्या होगा, 5 साल बाद क्या होगा. आप मेरे से रात भर बात करिए, लेकिन मैं ये 2 लाइन से ज्यादा तीसरी लाइन नहीं बोलने वाली हूँ. आपकी ये प्रॉब्लम है, आपका ये ट्रीटमेंट है, आपका ये डिसीजन है, और बाकी चीज आपके. जैसे टफ टीचर, जैसे हम सब लोग डॉक्टर शारदा जैन को पसंद करते हैं बिकॉज शी इज ए टफ पर्सन एंड टफ पीपल मेक अस टफ ऑल्सो. सो एज ए डॉक्टर शुड बी टफ, दैट इट इज दिस. बिकॉज अभी हम जैसे आपको थोड़ा सा लाइफ के, हम ऋग्वेद और बहुत कठिन बात नहीं कह सकते, पर जैसे अब पेशेंट हस्बैंड सास, अरे कैसे होगा, सबने लंबा मुंह लटका लिया, तो आपको कहना पड़ता है कि आप तो अभी नौजवान है और ये प्रॉब्लम्स आती हैं. और जैसे मिस अबॉर्शन की बात है कि आपने डॉक्टर लीना ने ब्यूटीफुली कहा कि भाई 100 में 30% बच्चे ह्यूमन रिप्रोडक्शन ऐसा होता है और यूजुअली अच्छा होता है. सो व्हाट इज अ मिक्स ऑफ प्रोफेशन, कंसर्न एंड अ लिटिल लाइटनेस ऑन बोथ पार्ट. अगर हम भी ऐसा कहेंगे कि हाँ एक मिस्ड अबॉर्शन या एनी कॉम्प्लिकेशन इज दैट बिग, हम लोग भी ऐसा इनडायरेक्ट मैसेज देंगे तो वो भी हमारे कहीं लाइक दिस फेवर में जाता है. एंड फोर्थ थिंग ऑफ डॉक्टर लीना, बॉन्डिंग आउट. तो ये मैं सबको, whosoever ऑडियंस इज देयर, आपको कोई लग रहा है कि ड्यूरिंग सर्जरी द ब्लैडर इज रप्चर्ड, यस इट इज रप्चर्ड, तो बॉर्निंग आउट, हम ये नहीं बोलते कि ब्लैडर रप्चर है, हम ये बोलते हैं कि ऑलरेडी देयर वर सो मच एडिशन, इट वाज ऑल लाइक एडियर्ड and we tried our best. So they are now, we have to make them like aware that we have done, we have come out of the worst what she had. तो ये कुछ छोटी टिप है. never be fearful, never be like angry, and the challenges don't bring that thing, because always the medicine humbles us. And thirdly, that you should be professional and the concise, and don't take too much, you stick to that thing and that's it. And professional, that is not, the counseling is not pampering her emotion, but we have to be very clear like a professional. So these are 2 or 3 things I think we can, and we have to come with the purity. Because fourth thing, yes, if it is a little time, take always interest in the patient, like उसके पुराने records हैं. कई बार हम कहते हैं हाँ ठीक है, जल्दी ब्रश अप देख लिया. You have to take interest in the patient. कोई पुराना आता है अपनी बेटी को दिखाने, ये बच्चा हुआ था अब 10 साल पहले मेरे लिए, रात में 1 बजे उठी थी. टेक इंटरेस्ट इन देयर लाइफ, क्योंकि हम लोगों को ज्यादा काम करना है, और जब ज्यादा काम करना है तो हम हल्के इस तरह से हो सकते, बहुत ज्यादा हैवी बन के नहीं हो सकता. अच्छा आपने नया शर्ट पहन लिया, अभी तो आप बहुत स्मार्ट लगने लगी हो, पहले तो आप ऐसे थी. टेक अ लिटिल इंटरेस्ट, एंड दैट इज नॉट ए पार्ट ऑफ काउंसलिंग, दैट मेक्स अस लाइटर. And we are lighter in profession, we are happier in profession, we can do more work also. So these are the few tips to, like, few experience which I shared, and this is a wonderful evening. Both Dr. Leena's presentation was something heart-touching, memoir of so many situations when we really become a little bit disturbed, and all the role plays. Thank you very much for the opportunity.
Pure and firm. That was your message, ma'am.
Yes.
Thank you so much. I would invite Dr. Gaurav now to give his expert opinion. Dr. Gaurav, please.
Thank you, Dr. Shakuntala. Am I audible?
Yes, you are audible. Very much audible.
Okay. So I'll commence from where Dr. Shada Jain left. See, dear friends, the NMC has now introduced almost 180, to be precise, 179 new hours in medical education for the undergraduate curriculum starting 2018. And it has only 4 things. What are those 4 things? It has only 4 things, and those 4 things are ATCOM, and ATCOM includes attitude, ethics, and communications. If you will have a look at this slide being projected right now, the first one, it says domains of learning. So, this is a very new concept that has been introduced into UG medical curriculum, MBBS. Traditionally, there were only 3 elements or domains of learning, KSA, knowledge, skills, and attitudes. Now they've added the 4th domain, 4th dimension called communication. And they prepared a very detailed ATCOM module to be followed in letter and spirit by each and every medical graduate. And it has all the competency, entire medical curriculum has now been stratified down to the last detail in form of competencies, and which competency has knowledge, skill, attitude, and communication, which depend upon the type of teaching that we want the students to perceive and learn thereon. Now again, all these things are part of the ATCOM module, which has starts from first day of MBBS and goes on to the last day of MBBS. And all of these things, almost you'll be surprised to know that 25%, 1/5, 20% of the entire ATCOM module constitutes communication. And there are 5 dedicated modules based upon communication. And these modules are taught in the form of an exercise. They range from anywhere between 5 to 7 hours. Now, ऐसा नहीं है कि 5 to 7 hours at the same stretch कराना है same day में. They may be spread over 1, 2, or 3 days. But the idea is that each student is assessed in detail of all the aspects of communication learning, And if you would please come to the next slide, please. The second part is that each student is now assessed, officially from for 7. There is something called as Kalamazoo consensus. It might be something new or foreign that I might be, you might be listening for the first time. But this is, very much part of MBBS curriculum. और इसमें आप देखिए कितना important 7 चीजें हैं और हर स्टूडेंट को असेस किया जाता है ऑन ए स्केल ऑफ 0 to 10, and for a good communicator for each student it has to be somewhere close to as close to 10 as possible. Now this is what we're learning now, and of course there was nothing like this in our time, so we have to catch up with them and learn all these things. So it just goes to show the importance and the seriousness with which the MC is taking up all these things. Having said that, we can have there is no more slides now, so there is no need of projection. So just a small word on legal aspect and another word on spiritual aspect. So see, whenever the patient comes to us,
मैडम ये स्लाइड हटा दीजिए.
so when the patient enters our consultation chamber, patient is many a times assessing our character as such, and उसका जो first impression आता है हमारे thought से आता है. Non-verbal communications are more important. Imagine yourself, you are sitting on a stage delivering a lecture session for an audience of 200 people. Now imagine, how do you sit? You sit very tight, very stiff. You are very, very conscious of your body कि एक मेरा grimace ना हो जाए फालतू, एक action ना हो जाए. अगर नाक पे मक्खी भी बैठी हो तो मैं हाथ नहीं उठा सकता उसको उड़ाने के लिए. Because what are you thinking? That all those 200 people are watching me very cautiously. Now imagine those 200 people, they are sitting right next to you, 3 feet away on in your consultation chamber. The patient is assessing you in detail. He is examining you. You are going to take history and examination, but the patient is examining your character. So all the non-verbal is appearing on your, the eyes are the window to the soul. So अगर आप परेशान हैं, angry हैं, irritated हैं, tired हैं, all these things are reflecting through your face, through your eyes, and the patient can assess everything. We need not tell the patient. So this is one aspect, that everything has to starts from the thought, and every thought goes on to the patient. तभी तो कहते हैं ना कि I was just thinking about you. तो कैसे वही thought होता है. Lastly, just a small thing about legal aspect. As far as communication is concerned, there is a very important section 93 in the Indian Penal Code. If I were to say, where is it mentioned that communication, what is the importance of communication legally speaking? So it is this very section that is important legally. And it says communication made in good faith. What is it about? If you tell a patient that you have such, you have cancer, you have a heart attack, and due to an unfortunate repercussion, the patient dies. So the doctor in such a situation is not criminally held liable. What does it mean? That the doctor is not liable for punishment in a court of law. Civil compensation बनेगा वो अलग बात है उसके लिए कि उसको breaking bad कैसे करना चाहिए था, what we all learned. But as far as communication legally is concerned, the doctor is pretty safe from an act done in good faith. वो 92 होता है, but from communication done in good faith, वो 93 IPC है. So that was just a legal aspect. Dr. Shakuntala, that was all from me.
Thank you very much. The spiritual and the purity.
The national board has also come up with a curriculum, and all the DNB candidates are also going to be assessed. They are also going to have training sessions for teachers, how to teach communication to the students. वैसे भी कई चल रहे हैं.
We already have medical education technology workshops being held throughout the country, and we have got a basic course and an advanced course. And no medical faculty can teach MBBS students without having undergone the advanced course. And for that, they have made it mandatory that during a inspection by the erstwhile MCI, now the NMC, a doctor, even if physically present, has not undergone the advanced course, it's called Advanced Course in Medical Education, ACME, then he will not be counted as a faculty in that medical college. It is so serious from their point of view.
They have taken it very seriously now.
Yes.
Dr. Sharda ma'am?
Will be
I
holding
think
a work.
all people have commented every bit of it, and I think it has become concise, but I just wish to just tell you 2-3 things. It was highlighted that, the old records must be seen. I think whether your junior does it, the salient point must be seen. And secondly, all the answers question must be answered. Unanswered questions are irritating. They at times annoying, and then it leads to, because they want some attention, and that's why the lawyers chip in and they make things against you. So I think make it a point whenever the patient is admitted indoor, or at the time of day care, this thing, when they're getting discharged, you ask them if they need any queries. I have taken one more thing. Not that I have less litigations in my life, but I find after surgery, do talk to them that their two WhatsApp consultation will be free, and they're free to ask on a day 1 and a day 2. So I think that probably eases out that any questions are remaining with them, they must be answered. I think questions must be answered. That particular part must be seen. Wind up, Dr. Shakuntala.
Dr. Shakuntala, we have Dr. Asmita with us, so I think we can have expert comments from Dr. Asmita too.
Madam Dr. Asmita.
Yeah. Good evening, and I think Dr. Leena, it was really a very wonderful presentation, and I really enjoyed. I mean, communication skills is something very personal. Every doctor has its own personality. Every patient has a personality, and we cannot have a single formula which will work for every situation. But yes, it's an acquired skill, and as a medical graduates, as we teach all our students now that we are lifelong learners, every patient teaches us, every patient interaction evolves us. So I think the basic key which we need to remember, that give enough time to them, give due respect to their complaints, their questions, queries, and at the same time, as Dr. Ragini said, there might be some patients who are over impinging on your time or something. We need to balance out those situations. So there is no single formula. And one thing I would say, it's not only the doctor-patient communication, but communication within the team with which we work is very, very critical. Undergraduates, we teach EdCom modules, but now our postgraduates, we have started teaching them the soft skills. How you communicate within your team. Most of the reason for our problems and complications which we face are the communication failure within the team. So communication skills, I think, are part of our life, whether it's our personal lives, whether it's our professional lives, whether it's patient or whether it's within the team communication. We have to acquire and evolve our skills throughout our life. And I think it was a brilliant presentation, excellent session, very nice role plays. We need to keep on doing this more frequently to reinforce our inherent skills and improve them further. Thank you so much for making me part of this event. Thank you.
Dr. Shakuntala, if I can add,
Asmita, your center is a nodal center for the NMC. As for the medical education is concerned, will you want to say something about that?
Yeah, ma'am, we have a nodal center for medical education where we train the teachers from, I think, most of the North Zone regarding the teaching technologies, then assessment and communication skills. But the basic communication skills are part of our undergraduate teaching. And now department-wise, we do conduct it for our postgraduates. Like today, only for our PGs. The next team which is going to go into our labor room and casualty from first, we have sort of a reinforcing session to them, because casualty, labor room are very sensitive areas where patients also are very sensitive. The chances of conflicts are very high. So we do try to give them little bit reinforcement and some SOPs to work in these areas. And I hope it does affect. I mean, there is no objective way to assess what is the impact of all these endeavors we do. But we do expect that it will reduce some sort of a conflicts which we face, because nowadays there is a lot of violence in our emergency areas where patients are not satisfied, and so it's ultimately we have to navigate ourselves with our communication skills and our the administrative reforms, so that the conflicts are minimized.
There's just a little point I would like to add with the permission of the chair.
Please, ma'am.
Yes,
Please.
You see, Dr. Asmita has highlighted an important aspect, that is communication within the team. And I think it goes even further than that. And this, the people who's your security, your ward ayahs, everyone should be taken within this loop of communication. वो बाहर से ही वो क्या सिक्योरिटी बोल करके अंदर भेज रहा है और बाहर से अंदर देख करके क्या बोल रहा है, उसका बहुत बड़ा इम्पैक्ट होता है. एंड वी हैव सीन अ लॉट ऑफ प्रॉब्लम्स अराइजिंग बिकॉज ऑफ दिस. द डॉक्टर्स आर डूइंग देयर बेस्ट. Everybody is doing their best. SOPs go a long way, but we are talking about our own medical and paramedical thing. I think we have to take our communication out of the medical and paramedical and go beyond it to anybody who's involved in hospital care or who is there at the gate, how he tackles the patients and what he says, what he doesn't say, the way. I think that is also important, and probably management should be taken in so that they can inculcate all these things. We doctors cannot take responsibility of all the communication, but the management should definitely, so then only it works as a team. For standalone centers also, it is an important aspect, because standalone centers, it will be the doctor, poor doctor. I really feel sorry, and they are very brave, the standalone centers who are running them, and you have to deal with everything. But I think they also probably need to never speak ill against the other. We will always try to help each other.
Yes, ma'am. Absolutely.
Yes.
Dr. Leena, if I may add something, not really adding, but it's just an example. We learn a lot from things. So my mind from your talk, Leena, has gone on to so many epics and other scriptures and other things. One thing we learn from sports. What do we learn? So when we talk about communication, as Dr. Asmita has said, it's not only, and Dr. Basu has said, it's not only with patients. Communication with your team, communication so that the security guard and the general duty attendants, everyone is in the picture. So one example is sports. So sports, they all make a circle and huddle. They huddle. So they discuss things, they communicate, then they plan, change the strategy. And in this thing when they have an interval, and so we should have team briefs before any delivery, before any surgery, and the team brief can be really brief. And at the end, to communicate after a certain operation has been done, we should have a team debrief. So communicating within the team debrief without a blaming attitude teaches the whole team a lot. So team brief, team debrief, these are also aspects of communication, and we learn this from the sports area. So sports teaches us to huddle, to be together and discuss a strategy.
We can learn it from
I'll take a little further, I just wish to just tell you that 95% litigations these days are motivated by your own colleagues. So what madam has said, that you must take an oath, whatever we try to do, we should see that, that kind of fellowship feeling should be with us, that we should keep shut and we should not speak anything against them, and also promise that we will not instigate our against our colleagues. I think that's very bad. 95% is the estimate given by the National Medical Council.
My goodness, such a high number.
And however transparent and looking into the eye of the patient and communicating we should be. But remember what I have learned, that we have to understand the whole thing, use our intelligence to understand what's going on. Remember from the previous episode of similar kind, how we dealt with it. And the doctor should have a little shrewdness. The doctor should not be wicked, but the doctor should be intelligent, well-read, updated, and a little shrewd. Then only you can protect yourself.
I think we should also include, concentrate on training in emergencies, all kinds of emergencies, whether it's labor ward, bedside emergencies, because that is where most things go wrong. Whether you're performing a surgery, all other surgeries, anything which is elective or planned, you tell them, at least we make a point that आपको Google search करना, Yahoo search करना, विदेश में किसी रिश्तेदार से बात करना, नेबर से बात करनी है, सब पहले कर लीजिए, क्योंकि उसके बाद फिर आप फैसला लीजिएगा, तभी हम लोग करेंगे. बिकॉज करने के बाद then they begin to ring up, उसने ऐसा बोला था, आप नहीं कराते सर्जरी, ये करना. जो होमवर्क है आप पहले कर लीजिए. Once you are convinced, and if you give them that freedom, you must make them partners. When we talk a lot about shared decision making, but then shared decision making amounts to the fact in practical terms कि क्या हम करने जा रहे हैं, the फैसला should come from them.
And communication के साथ documentation भी जरूर होनी चाहिए.
बहुत जरूरी है. बहुत जरूरी है.
Documentation तो बहुत जरूरी है. Once you write down, I advise this and it is refused. आपको कुछ और ज्यादा समझाने की जरूरत नहीं. I advised and it is refused. खत्म. तो फिर वो दो बार सोचेगा कि मैडम ने क्यों कहा, इसका मतलब ये चीज important for myself.
Madam,
So I think we will should wind up, Dr. Shakuntala.
D was dedication.
Anybody wants to make any comment? We still have our 5 minutes. We can take it up.
Dr.
Madam, जब हम लोग student थे तो वो D stand for the dedication. Now this D stand for the documentation. So all the C goes to capability to communication and D dedication to documentation.
Right. जी मैम.
One
ABCD हो गया.
that
ABC से बदले ABCD हो गया.
one said that anything should not be taken heavily. Like we learned indirectly बहुत सारी चीजें, लेकिन हम सब लोगों ने अपनी personality के हिसाब से invite कर लिया होगा. So always this is very very important that it should not be very like heavy on us, but it should be very lighter mood and the lighter environment. So because अभी क्या होता है, जो मुझे लगता है कि रैगिंग नहीं होती, बच्चे यूनिट फैमिली में एक पूरी जनरेशन डॉक्टर्स की और पेशेंट की तैयार हो गई है जिनको कुछ बर्दाश्त नहीं है. Any bad thing, any bad language. So we have to understand, like as a doctor, we have the opportunity to read diverse human behavior. And कोई लीडर है, कोई नेता है, कोई गरीब है, कोई बहुत अमीर है, कोई ऑफिसर है, and we should take it as a what Dr. Smita says as a lifetime teaching, and we should not be हम लोग बहुत overburdened रहेंगे तो भी परेशानी होगी. Document it and that's it. आप करिए काम और फिर खत्म करिए. तो because हमारी मेंटल हेल्थ के लिए भी बहुत जरूरी चीज है. हाँ, yes मैडम.
नहीं, इसमें I would just like to give an example when you talk ना कि एक जनरेशन खड़ी हो गई है जिसको कि एक बर्दाश्त नहीं है. It's a very practical thing we noticed. We have had 2 cases who were referred to us, and उसमें था कि one of them had an IUD with a singleton and the other one was one twin had died. So one twin was alive. जो जिनके 2 ट्विंस वाली थी, उनके साथ उनके माँ बाप वगैरह सब जो सीनियर और दादा दादी वो सब आए थे साथ में, और दोनों के रिस्पांस में इतना फर्क था. जो इंडिविजुअल न्यूक्लियर फैमिली वाले थे वेरी अग्रेसिव, रेडी टू फाइट, कि आप उनके बारे में बोलिए, हम लोग तो केस करेंगे. ये दे केम विद दैट एटीट्यूड टू द हॉस्पिटल. और जहां वो दूसरे वाले आए थे, उनका था दादा दादी नहीं बोल रहे थे हमारी किस्मत में ऐसा था, कोई डॉक्टर तो अपनी तरफ से कोई बुरा थोड़ा ना करता है, वो तो अपनी तरफ से अच्छा ही करता है. देन इट बिकेम सो स्टार्क बिकॉज दे केम वेरी क्लोज टू ईच अदर, कि जब कोई होता है ऊपर से बड़ा हाथ रख करके बोलता है किसी पर, तो आदमी उसको ज्यादा संतुष्टि से ले लेता है. और वो चीज अभी की जनरेशन में मिसिंग है. तभी ये सब इतने डिस्कशंस हो रहे हैं कम्युनिकेशन पर कि हम क्या कर सकते हैं वही करें आज के माहौल में. नहीं तो पहले जो था, ये बड़े लोग जो ना बहुत समझा देते थे कि लाइफ में बहुत कुछ होता है, चलता है, एंड दे हैड नो प्रॉब्लम एट ऑल.
Dr. Kusum Sani is also with us. Dr. Kusum, can you just give a few small comments because you have so much experience?
Ma'am, in front of all these stalwarts who have so much of experience, of course, every patient teaches us what you should be saying and what you should not be saying and how you should be saying. Because as Dr. Basu said, 2 patients, at a small interval they came. They both had almost similar situation, but the response was totally different. So we have to be careful about our own mental health also. Correct. Sometimes you really don't know how they're going to interpret, because so many of them would only like to interpret it the way they want it. You may be saying anything, but their interpretation is going to be whatever they have fixed in their mind. Thank you, ma'am. Thanks for giving me.
They go around.
Should you, Dr. Leena, do you feel that it is wise to have another doctor with you when you are communicating something to a patient, especially if you are breaking bad?
I think this should be covered with video consultation or some recording.
Yes.
We have a patient counseling form. A patient counseling form which is signed by the attendants and the relatives and everything. so that, we have this
No,
document.
can we have another doctor in the room where we are speaking with relatives?
Yes, ma'am.
Should we have? In fact, include the
Whenever there is a bad news, we should have the whole team with us.
Full team should be
Yes,
there.
ma'am. Yes. Dr.
Yes,
Dr.
absolutely,
Gaurav,
ma'am.
Dr. Gaurav, you are the most practical. So I think your suggestions are truly so very valuable. So what do you feel? How do we protect ourselves? Okay, not making very bad news, but yeah, something like an intrauterine fetal death. So should we have other people?
Other than being a human being, other than having a human being around, I would go for a camera being around and watching, observing, recording all those things. See, whenever we are taking a high risk consent from the patient, nowadays camera with audio recording is all recommended as a mandatory instrument. Similarly, in the same scenario, while Breaking Bad, I would definitely recommend that you do it under CCTV surveillance and let everything being recorded, that they have been adequately informed about the same and about the repercussions of the same, and that tomorrow these are the only issues that crop up and they go against the doctor. Here I would like to cite an example of a communication gone very bad. So this is regarding a case called V. Kishan Kumar versus State of Tamil Nadu 2015, only 7 years ago, where 1.38 crore compensation was granted by the Supreme Court because the doctor failed to, he tried to communicate, okay, that mother, it was an eye specialist and a case of retinopathy of prematurity, ROP, and the child was born blind. They could not diagnose in time. The neonatologist could not diagnose it in time. So, in the discharge summary, the eye specialist categorically mentioned that mother confident explained warning sign. And this was, can you imagine, this single line became the bone of contention where the Supreme Court categorically said that, okay, the doctor communicated and documented at the same time the same thing, but he failed to communicate and document what are the warning signs. और पेशेंट के मदर की कंप्लेंट यही रही कि मुझे तो जी ठीक से बताया नहीं, जबकि हो सकता है बताया होगा डेफिनेटली, तभी डॉक्टर ने लिखा, और इसकी वजह से 1.38 करोड़ कंपनसेशन दिया. And so, when we talk of consent, we say it is the most important document. I agree. But if you were to ask me, which is the second most important document in the medical life of a doctor, without hesitation, I would say it is the discharge card. There have been many cases where courts have gone, have been very harsh upon doctors and hospitals because the discharge card did not have proper instructions to be followed upon discharge. So the guideline is that each and everything that comes to your mind, I like that, I often like to quote, whatever you think has to be there on paper. You speak it, you write it, you document, preserve it. So it has to be very, very specific. Here, if you have to take 2 minutes extra to jot down on that piece of paper called discharge card, to take 2 minutes, 4 minutes, but write down 10 points, 11 points, 15 points, but they have to be very, very specific. किस दिन आना है, किस टाइम आना है, alternate treatment क्या है, emergency में कैसे contact करना है, किसको करना है, all those things other than medicines we are very fond of writing, but we forget कि ठीक है all क्या instructions हैं to be followed. So it can, the lack of communication can cost us crores of rupees. That is the message that I want to be given through this.
Very true.
So the next Pathshala we will have either death on the table or abdominal pack left inside.
Right.
So that would be our talk because that bothers a lot of doctors and it happens in everybody's life. So I think that will be a point of discussion next time.
That will be great.
And how can a doctor defend in such a situation if a mop is left inside?
Right. So,
right, sir.
If that is all, then I would just request Dr. Raj Bokaria to wind up and give a note of thanks, a brief note of thanks to everyone, please.
At the outset, I thank each and everyone who joined this session for their valuable time. and making it as a great success. And my special thanks to instrumental and the driving. And I congratulate Dr. LEENA for her excellent deliberation with so many key points how to improve this communication. And I think each and everyone who are the expert with their expert inputs and comments are going to be very fruitful in their clinical practice of each doctor if we adapt them. But most of the doctors, they don't have this communication skill, and we can always have a learning if we want to. And after hearing this session, I think we should improve our communication skill, learn this, achieve this art, and this will prevent the litigation in future. Definitely it will not totally stop, but it will definitely improve and reduce the litigation. I also, the role play by all our doctors was an excellent. Both the of the communication
आपको
very
लगता है कि
well,
अगर हम
giving
ओथ
a
गूगल
clear
फॉर्म में
message
ले
we
तो
should
ये
not, we
हमारे
should
को थोड़ा
listen to
सा
them.
सेल्फ रेगुलेटरी इफेक्ट रहेगा कि दैट वी विल नॉट स्पीक अगेंस्ट डॉक्टर्स एंड वी विल नॉट इंस्टिगेट आवर कोलीग्स.
I think we should take a vow because
we should take a vow in that. That's right.
Madam, like the rule of karma, I mean, I think we should all be afraid. I mean, we should think of the God Almighty, and we should have this thing. Today it has happened. We are saying this. Tomorrow it will happen to us. I think that little bit we have to constrain ourselves at the end of it
you
all.
know, in all these years I have seen कि theoretically बहुत लोग believe करते हैं कर्मा होता है, ये होता है, पर जब actual काम पर आते हैं ना, तो वो चीजें सारी हवा हो जाती है.
Right. Yes.
घर छोड़ के आते हैं उनको.
वही चीज हमें.
Yes. I think, you know, I was telling the national board that we should include a bit of philosophy and psychology in our medical studies.
Yes.
Because जब तक ये भी थोड़ा सा नहीं समझेंगे, तो बाकी चीजें
should be having some spiritual and all these whatever the Veda and all.
Absolutely. I feel very strongly. If you read some brief Veda, you will understand what impact.
You would be interesting. It is interesting to note.
Course for on that.
It is interesting to note that पुराने ज़माने में,
Dr.
पुराने ज़माने में भी they have
who have joined today and
we are Indians. We have to read our scriptures, our mythology. That has a lot of impact on us. Very positive impact.
Dr. Sanjeevni, very impressed with your knowledge of Vedas.
Dr. Suman, your acting was superb. Absolutely. All of you were so good, Shakuntala, Dr. Seema, Dr. Sonal. And of course, needless to say, Dr. LEENA just started it all off. Brilliantly.
Madam Sanjeevni,
Thank you so
patient
much.
को भी तो कोई scriptures और humility पढ़ा दे कि सारा हम ही